When I went in, I was expecting them to say, oh, you got the best arteries I've ever seen because I'm healthy and fit and eat properly. Been on fish oil tablets for the last 8 years and they're meant to be good for you. So I thought he'd have a look and say, oh no, everything's fine, must be nothing. And when I got told that I'm going to need triple bypass, I was sort of a little bit of shock, couldn't believe it. Felt a bit ripped off that, like, age of 47 that I had to go through what I had to go through.
I think if they're waiting for surgery, it depends what the condition is. If they're waiting for surgery, we need to be a bit cautious. I think the most important thing then would be that they understand how to manage any symptoms whilst they're waiting for surgery, and then what to do if the symptoms become more intense or more frequent.
Bypass surgery is extremely common. It's in fact the most common operation performed in the Western world. It's a big operation for the patient, but in most circumstances it's not a big operation for the surgeon. We do a number of those operations every week and it becomes a very routine procedure for us.
You'll have met the surgeon and the surgeon will have talked to you about the risks of surgery. The surgeon will be honest with you. Your risks will be determined by your age, your other illnesses like diabetes or lung disease, and the surgeon will have outlined to you what he's going to do. And this operation will be at a risk. Now, 30 years ago, that risk might have been 5% mortality. Now that risk is going to be closer to 1% mortality. Might be less than 1%. And he'll be honest with you about the risks of complications. He'll explain that if you don't take deep breaths, you might get pneumonia. A tiny percentage, but it might be as much as 1% in some people, might get a stroke. A great fear for patients coming in. But they'll have had that meeting with the surgeon with a plan that they've understood why they're coming there. Their cardiologist would have told them that too. But they're coming in with their eyes open, certainly fearful, and we know they come in with their families anticipating horrible things, and they meet all the people who are going to look after them. It's a very helpful thing that they meet the physiotherapist, the cardiologist attached, the surgeon, the nurses. They are all part of what has to happen.
It's good to let them know what the procedure consists of, what they may experience as they're waking up, and sometimes that can be quite a frightening time for them, and the intensive care period, and then also what it's like to expect when they're recuperating back on the ward. And really telling them that, yes, there may be some uncomfortable days, there may be some periods where you really don't feel very well, and what to expect.
Bypass is a much bigger procedure than a stent, so that's the first thing. And usually you'll be in hospital somewhere between 5 and 7 days. The preparation is different to a stent. You have to have a lot more work up in terms of blood tests, x-rays, lung function tests. The preparation of the actual body is different because they've got to shape the chest and get you ready for a midline cut through the bone in the middle of your chest. And then there's a lot more aftercare as well because it's obviously a big anaesthetic and you're very deeply asleep for a day or so after, and then you'll be groggy for another day. So you won't remember very much about it for probably 2 or 3 days basically. And then there's always the aftercare, so you spend a few more days up in the ward recovering from your wounds, and the cardiologist will check you every day and may need to give you some medication to get rid of some excess fluid that they may have pumped into you during the time of the surgery. And then we have to just make sure your heart's actually back into normal rhythm, which often is an issue immediately after an operation. Your heart may go into an irregular rhythm, so you may need some medication for a couple of days or longer to stabilise the heart rhythm. So there's a few different things that can happen. Obviously it's a much bigger procedure. You have to open the chest, and you often have a wound on your leg, which is where the vein's taken from that actually provides the conduit for the bypass basically. Although increasingly more people generally use the artery off the chest wall, but that can only really generally be used for the artery at the front, although some surgeons do use the artery on the right, so that's a slightly different procedure, but many people use the vein from the leg still. So you have to really deal with 2 wounds, and actually the wound on the leg can be more of a problem than the chest wound a lot of the time. So the chest wounds are held together with some steel wire, and that tends to heal up quicker because the legs takes longer to heal up and often is prone to infections that can slow you down for a lot more. So if you have the chest wound without the leg wound, it's a quicker recovery period basically.
Although it's major surgery, people now can go through their double bypass in a couple of hours, whereas when I was training, that double bypass would have taken 5 hours. The shorter the operation, the lower the risk. The shorter the time in bed after the operation, the lower the risk. So we get people up and going quickly.
Immediately after surgery, the patient wakes in the intensive care and can expect some degree of pain, although that's not usually too significant. The patient would expect to be nursed one-to-one in the intensive care and to have the breathing tube removed as soon as practically possible.
It is not unreasonable to tell people to expect to be home at day 6. They might be there for 10 days if they've got difficult diabetes, difficult lungs, or we're getting them onto blood thinners, warfarin. We have to stabilise their blood thinners, but an awful lot are itching to go home at day 6 and day 7.
Long-term recovery, I think, is a positive outlook. I think that combined with increasing activity, looking after one's cholesterol and blood pressure, will enable the patient to get the best long-term result from the operation. Obviously, the patient should give up smoking if that had been an issue pre-operatively, and the cardiologist really plays a major role in the long-term gain of the operation.
Hearts don't just get coronary disease, and often people can present with a problem that their heart can't get blood out of the heart because there's a narrowed aortic valve, for example, or it's inefficient in its pumping because there is a leaking valve, a leaking mitral valve. And these valves in the heart can be affected by factors such as rheumatic fever, or they can be affected by degenerative change, so that a person might have been born with a slightly abnormal aortic valve. They were perfectly fit and well apparently as they were growing up, but this double leaflet rather than the 3 leaflet aortic valve starts to calcify and narrow off as they get older, or it might calcify and start to leak as they get older. And so that person might need their aortic valve replaced.
Patients require a valve replacement either because the valve is narrowed or the valve is leaking. Most commonly with the aortic valve, this tends to get narrowed as patients get older. Sometimes with the mitral valve, the valve can leak because of a mechanical problem, and occasionally a patient will require valve surgery because of an infection on the valve. It's essentially, as far as the patient's concerned, very similar to a coronary grafting procedure. The patient will usually have an incision called a median stenotomy, which is a cut down the centre of the chest, about this big. The patient's placed on cardiopulmonary bypass, usually for a period of between half an hour and 1 hour, and the heart is stopped and the valve is replaced. I say to patients it's often like unblocking a drain. Once the drain is unblocked, the problem's essentially gone. Depending on the type of valve that is used, the result should last between 10 and 20 years.
We're living in a good age in terms of what is available, and as most of the treatments these days have minimum side effects, which is the good news, and actual sort of techniques have improved over the years. So in terms of the time off work or quality of life issues, many people get back to a normal life very quickly even after heart surgery. So, and that's really what our aim is to, apart from keeping people alive, is to actually give them a good quality of life. So that's just as important as quantity as quality, obviously.
You've got a range of medications that have been prescribed to you by your cardiologist or your GP, and that can be quite daunting for you to think about having to take all these pills and having to manage them all.
Well, it makes me feel old, actually, getting them all out, every Sunday or whenever it is I do it, and putting them all in their containers. I think, this is for old people, I'm not old. So from that point of view, I guess you have to be confronted with your own mortality. I don't know if that's the word, or you are in that same category. You have had some serious surgery, and you just have to really put up with, that's part of it, And then you put up with your friends saying, you're still taking warfarin, that's rat poison, and things like that. You just have to say, well, unfortunately, I have to have it.
A drug called warfarin basically is a drug that's used in a number of conditions. In the cardiac setting, we'll use it for two main reasons. If a patient develops something called atrial fibrillation, which is basically an irregular or rapid rhythm to their heart, there is a real risk of stroke. Because when the heart is beating rapidly and quickly, it tends to make the blood very turbulent inside the heart. And what can happen is you can form clots or scabs inside that heart, and those can fire up into the brain, causing a stroke. So to prevent that, certainly the drug of choice at present has been warfarin. One of the other classic areas that it's used in is if someone has a mechanical valve put into their heart through a surgical procedure, they must be on warfarin and will be on it for life in that setting.
I've been doing cardiology for over 30 years, and I think that I am staggered by how well people do after cardiac surgery. After bypass graft surgery, they could have been dead, and now they're living for an extra 20 or 30 years. They were facing sometimes death at a very premature age, and now they're living for all those extra decades. We are giving them very much a freedom to be independent as they get old, a chance for their grandchildren to enjoy grandparents still around, and there are so many benefits. And I've come to appreciate that over the last 30 years. I think it's a very good thing to have heart surgery.